So we'll start with the previous classes continuation, which was disrupted. So today we'll continue with determinants and disorders of growth, along with certain growth charts, growth monitoring charts as well. Okay. So childhood and infancy is the period of prime growth. Okay. And it usually refers to our skeletal and linear growth. Okay. The growth in height, the growth in length and height. But along with that, every organ system in the child is also growing, including the reproductive system, the central nervous system. The growth of all this is completely dependent on the child's adequate nutrition. But when you are an adult, okay, your growth is not dependent on nutrition alone. A lot of hormonal factors, stress factors, environmental factors will also play along with that. Okay, but if you are a child, if you are an infant or a child, your growth is completely dependent on your nutrition, on adequate nutrition. And if the child is malnourished, the growth will be directly affected. Okay, so linear growth the framework is what we focus on from infancy, childhood, and puberty. So ICP model, I'll show you the graph of that as well. So the complete growth in this infancy and childhood is dependent on nutrition. In puberty is where your hormones, sex hormones, and the androgens come into play. Okay. So ICP model, infancy, childhood, puberty model, describes a human growth from the later half of the intrauterine life, that is after birth, to maturity, that is puberty, okay, adolescence, as three additive and partly superimposed components of infancy, childhood, and puberty. Sometimes you can completely do a different graph for infancy, a different graph for childhood, a different graph for puberty, and some cases you can completely superimpose all these graphs together in a continuation from infancy to childhood and puberty. I'll show you the difference. Okay, superimposed graph and a different graph. So infancy component is largely nutrition dependent. Okay, in infancy, when the child is an infant below 1 year of age. Okay, and in childhood, component is mostly dependent on growth hormone and nutrition. Okay, but when it comes to puberty, adolescence, okay, it's a synergy between your sex steroids, that is sex hormones, and growth hormone. Both are required here. Okay, but in infancy, completely it's nutritional based growth. In childhood, nutrition and growth hormone. In puberty, that is adolescence, it's a synergy of your sex steroids along with that growth hormone. Okay. So the ICP model offers a method for detecting abnormalities in the three components so that early intervention can be targeted and therapy can be monitored. Okay, so with the help of this ICP model, the graph which I'll show you, if there is any slight deviation of this graph from the normal growth, immediately we can understand something abnormal is going on. Either the child is not well nourished, or the child is not producing good amount of growth hormones, or the child is not producing enough sex steroids. Okay, so it could be any of the given situation. So it can be detected as early as possible, and nutritional therapy can be given. Okay, just give me a moment. So this is the model, okay, ICP model, the graph. So if you can see here, from this purple line, if you extend, it goes into an orange line, and then it goes into a red line. So this is the superimposed graph, one on top of the other. Okay, but you can draw a completely different graph also, just to differentiate three of these components, three different phases of life. Okay, in infancy you can see the growth is so rapid, because you can understand by the age of 1, by the first birthday, the child's weight has to triple. Okay, the birth weight, where the child is born with or 2.5 kg of birth weight. Okay, by the time the child is reaching 1 year of age, the child's birth weight should be around 7.5, okay, or 6 or 7.5, something like that should be there. So that is how steep the growth is. So you can see how different the infancy, the purple graph is as compared to the yellow graph. Yellow graph is the childhood growth. Okay, after infancy, preschoolers, toddlers, and schoolers childhood growth, it is completely based on growth hormone. Okay, infancy is based on nutrition. Okay, the impact of growth hormone is not much on infancy, in infancy when they are growing skeletally or when the linear growth is happening. Growth hormone does not have an important role here, but in childhood, growth hormone has a very important role. Okay, along with nutrition. When it comes to puberty, teenage, you can see how the growth is. It's you will not see drastic growth. Obviously, there is a peak, that is the growth spurt. Sudden peak is there, but then it remains the same. It does not come down. It remains the same. It means the child has, or the individual has developed, have become mature. They will no longer grow linearly. Skeletally, they will no longer grow. Okay, they can put on weight. BMI can increase later on in the life, but height will not grow much. Okay, so this is the puberty hormone based on sex steroids as well as growth hormone. Okay. Hormonal regulation of linear growth. Thyroid hormone, growth hormone, insulin-like growth factor, androgen, and estrogen, they all positively regulate the linear growth. Okay, so all these hormones in a well-based concoction like release, if it is happening, means the individual will be healthy, the individual will achieve a proper growth. But if at all the other hormones are working fine, but even any one of these hormones are not secreted properly, hypersecretion or hyposecretion, that could negatively impact the linear growth as well. Okay, so a proper concoction of all these hormones secreted regularly in the normal pace will lead to a positive linear growth. Okay, and a regulated linear growth. Okay, hypersecretion can give you gigantism. Too much of growth hormone can give you gigantism. Okay. Consequently, deficiency of these hormones can also present clinically with decreased linear growth. The height will be small. The child may not achieve proper height as compared to their peers. So growth hormone is considered to be the key hormone which regulates the linear growth in child. Linear growth means what? The way how the child develops in height. Okay, we are not speaking about the weight here. We are just focusing on the skeletal development, the linear development, height development. Okay, so growth hormone plays a very major role when it comes to the regulation of linear growth. Next, we have failure to thrive, FTT. Okay, this is the next chapter. In paragraphs, they have given about the same concept. You can read it. You will get much more insight. But what is important regarding growth hormone, I have just took that in the previous slide. Next is failure to thrive, chapter 15. So now we are coming to the disorders of growth. What we have discussed so far is normal growth. Okay, how a normal child should behave in respect to infancy, childhood, and puberty, how the sex hormones and the growth hormones affect their linear growth. But what happens in case of abnormality when there is any disorders in growth? Okay, so FTT is the first condition, and FTT, failure to thrive, and malnutrition are closely related. Failure to thrive means what? Not able to develop properly. Okay, thriving, not failure to thrive means not able to develop properly as compared to the other average healthy kids of the same age. Okay, so traditionally used for, it is used for children who have failed to develop or grow normally. Okay, in general practice, FTT is commonly used for any child who fails to gain weight or height according to the standard medical growth chart, based on age. A proper a normal growth chart has to be maintained. We will discuss the growth charts also later. So in that growth chart, averages are given. If the child is of 10 year of age, what should be the average weight, what should be the average height, based on the child's ethnicity and everything. Okay, averages are maintained. Okay, so if at all the child is is too low or too above the average, that is also considered as failure to thrive. Okay, failure to thrive is a slow physical development in a baby or child development of in height or weight does not happen overnight. It takes time. So slow physical development in the baby or child is what we call as failure to thrive, and it is caused by the child or baby not having enough nutrition. One of the main reason for failure to thrive is not having enough nutrition. In other cases, recurrent infections. Children who are prone to recurrent infections, they also come under this category of failure to thrive. Okay, being health wise being down with infections again and again will also lead to slowed down or phased down growth and development. So failure to thrive, inadequate growth, typically in infancy and childhood, is what we call as FTT. There are three main types: organic, non-organic, and mixed. Okay, in organic, there will be a medical condition which is which could be underlying, like some congenital heart disorders, renal abnormalities, absorption issues. Okay, intake of nutrition may be affecting the child. Metabolism is reduced, like inborn metabolic errors. Okay, so the biological FTT is the preferred term here in organic. Okay, in non-organic FTT, another type of FTT. It happens because of insufficient calorie intake without any known medical condition. Usually, majority of the cases, we have seen that the children who suffer from non-organic or environmental or psychosocial FTT usually come from poverty, usually come from below poverty line households. Okay, uh, errors in feeding. Okay, so these all will affect the non-organic FTT. In mixed type, children who are born with some issues like cerebral palsy, both biological and social, already they have some underlying disorders. On top of that, the family is also not well equipped to provide good nutrition to the child. Okay, both these factors when they combine, it is called mixed type. Okay. So there are four main mechanisms of failure to thrive. Either one could be undernutrition, the child is not nourished well. The child's body, even if the child is nourished properly, the child's body is not able to use calories properly. Okay, there is increased caloric demand. Metabolic diseases are also increased. Okay, so these are the main mechanisms of failure to thrive. And various other complications are there. We will discuss about the complication in the coming up slides. So further discussion on classification, different failure to thrive is very broad. Usually, it is grouped as organic, non-organic, and mixed. In organic, failure to thrive refers to some disease condition or process or any multiple organ dysfunction the child may be suffering from. It is underlying, and because of that disease condition, the child is not able to thrive properly. It's not always because of nutritional deficiency. Okay, nutrition may be okay, nutrition may be moderate to good, but the child is having some other insufficiencies in the body, some disorders, some dysfunction that is causing failure to thrive. Okay, non-organic, it means the child is not being nourished well. Okay, emotionally, physically, the child is not getting proper nourishment and care within the family, either because of poverty, below poverty line, or family members unable to take care of the child. Okay, so that is non-organic. So in mixed type, it is both the causes when they come together. In certain cases, both the causes are there. Already the child has some dysfunction. The child is born with some medical errors. On top of that, there is nobody to take care of the child properly. So that will also lead to failure to thrive. So these are the complications that can happen because of failure to thrive. Malnutrition, that would lead to emotional deprivation, economic deprivation, not able to feed the child properly. Some ENT disorders, malabsorption disorders like celiac disease, cystic fibrosis. If the child is suffering from all this, the child will suffer from malnutrition. Okay. Genetic conditions like in the family itself, short height runs in the family, constitutional delay in growth, okay, small for gestational age babies and all, trisomies like Down syndrome, gonadal dysgenesis, that is the child's gonads. In the male child, the testes, and the female child is the ovaries, that they are not produced properly. Okay, other causes in endocrine disorders: hypothyroidism, panhypopituitarism. Okay, pituitary gland is not functioning properly, thyroid gland is not functioning properly. Okay, growth hormone is not created properly. Other hormones are okay, but growth hormone deficiency is there. Cushing syndrome, precocious puberty. Okay, and chronic system diseases like any cancer. Child is suffering from repeated infections, collagen-based diseases, congenital heart diseases like septal defect, okay, ventricle defect, atrial defect, okay, pulmonary diseases like cystic fibrosis, asthma, uh, and then malabsorption diseases, liver diseases, gastrointestinal diseases, IBS, renal inadequacies, nephropathies, anemia, so if a child is suffering from anemia, metabolic conditions like type 1 diabetes, glycogen issues, okay, maple syrup urine is an inborn error of metabolism like phenylketonuria. Cystinosis is producing too much of protein in the body, okay. Then skeletal disorders, chondrodystrophies, chondrocytes are not made properly, rickets, deficiency of vitamin D, mucopolysaccharidosis, osteogenesis imperfecta, not able to achieve proper lineal development, renal osteodystrophy. So these are the skeletal disorders the child may suffer from that could lead to failure to thrive. Central nervous disorders like mental retardation, any anomalies, tumors, hematomas, intrauterine growth retardation, infection, placental insufficiency, okay, they are also considered. Medications, methyl phenidate medication, which if the child is put on steroids for a longer period of time, that could also lead to failure to thrive. Okay, so these are the causes of failure to thrive. How to manage a child with failure to thrive? You have to do the nutritional assessment and intervention with the help of a pediatrician. Okay, pediatrician is involved in that. Along with that, dietitian or the nutritionist will be also in the core team. Improved parent-child interaction. Parents will also be given kind of counseling on how to take care of the child. Developmental stimulation. Maybe in some cases, growth hormones may be required. Okay, or hormonal replacement therapies can be required. Treatment and management of medical condition. If it is because of the medical condition, the child is suffering from failure to thrive, medical conditions has to be corrected. Okay. Support and intervention of social and family problems through any ICDS program, government program, nutritional programs. Okay. A lot of supporting programs are given by the government to support the growth of children. So make use of those nutritional programs. Mental health referrals where it is indicated. Only in cases where the child is suffering from mental health issues, referral is given. Regular follow-up care to make sure that the child is on the road to health. Road to health is also another graph which ensures that no child is going above or below the control limit. The child is on the road to health pathway. Okay. Next, we have short stature. A short stature, it's a general term used to describe a condition in which the child or a teen's height is well below the average. It's well below the average height. Short stature typically means that the person's height is below the shortest of 3% to 5% of the children in the same age or sex. Okay. So for example, 60% of the child or 70% of the children are in a particular height category, and if certain percent of children are 5% of them, their height is at least 3 to 5% less than of their normal peers, then we call them under short stature. Okay. Even under that, there are different degrees of stunting: first degree stunting, second degree stunting, and third degree stunting. Okay, if the height of the child is above 95% of what is considered normal, it is normal. If the child is 90 to 95% of what is considered a normal height, it is first degree stunting. 85 to 90% of the normal height is second degree stunting, and below 85 is considered as third degree stunting. Okay, so these degrees, these percentages, we get that from the Gaussian normal curve, okay, bell-shaped normal curve. We will discuss that later. From that is where we get all these percentages that determines if it is a third degree stunting, second degree stunting, or first degree stunting. So you can see here, this is the water loss classification. Height for age, if it is above 95%, we consider the child is normal. 95% is the group of the children who are in that age group. Majority of them who have a height, and if the child's height is also in that majority, it is above 95%. Okay. Causes of short stature, racial or genetic, like for example, pygmies in family. Okay, if the child is from pygmy family, pygmies are a race found in African countries, South African countries. Okay, so those are called pygmies. They are generally shorter in stature. Family, it runs in the family. If both the parents are also coming from a short stature family, the children may also be short stature. Next is constitutional delay of growth and puberty. For example, the child is delay in puberty may also run in family. In some cases, the growth spurt in children is achieved only after the age of 15. In some cases, it happens at an age as young as 10. Okay, so that depends upon how puberty runs in your family as well. Okay, low birth weight or intrauterine growth retardation, primordial dwarfing. Okay, these can also lead to short stature. Hypoplastic baby. Hypoplastic baby means such children during their uterine phase, when they were in the fetal phase, their organ development didn't happen properly. Okay, so they become hypoplastic babies. Chromosomal abnormalities like Down syndrome, Turner syndrome. Okay, in this also height is generally short. Metabolic disorders like Morquio syndrome. Okay, inborn errors of metabolism, phenylketonuria. Okay, that could also lead to short stature. Skeletal dysplasia like achondroplasia. The skeletal muscles or skeletal cells are not being produced properly. Nutritional short stature, that is chronic malnutrition. If the child was suffering from malnutrition from a very long time, that leads to nutritional short stature. Just give me a moment. Nutritional short stature, chronic malnutrition since childhood, since infancy. If the child was malnourished, and if the malnutrition continues into the childhood as well, toddler age, preschooler age, the child high chances the child will have a short height. Psychiatric conditions like emotional deprivation, if the child is not well taken care of by the family. Psychosocial deprivation, if the child does not have a good fun play group to play around. Okay, growth hormone will be reduced. Endocrine disorders like hypopituitarism, where pituitary gland is under functioning or not able to function properly, not producing hormones properly. Hypothyroidism, when the thyroid gland is not able to produce thyroid hormones properly, that leads to endocrine disorders and short stature. Then chronic systemic diseases like chronic kidney disease, congenital heart disease, chronic asthma. Okay. These are the causes. So these are the causes of short stature. Constitutionally small or small but healthy baby. So normal infants have normal birth weight, and the constitutionally normal infants, they will also have normal birth weight, but it is less than 10 percentile because of some factors like mother's height was less, mother's weight was less. If the ethnicity is like pygmies, or in ethnicity also they come from ethnicity which does not have huge babies, etc. And parity means how many times the mother has given birth. If it is a multi-pare mother who has given birth more than 2 times, there are high chances that the consequent births, okay, third child, fourth child, fifth child, may get smaller and smaller. Okay, that is a parity factor. And these in this infects there is no increased risk of perinatal mortality or morbidity. They are healthy, they're completely fine, but uh, they will be slightly smaller than a healthy baby, what we consider as a healthy baby, like almost 1 minute. So there is no increased risk of mortality or morbidity in constitutionally small baby. They are just smaller in height and weight, just 10% smaller than a normal healthy baby, but they will not have any other morbidity or mortality per se. Okay. So this is the classification of constitutionally small babies based on evaluation and ultrasonography examination. Even before birth, we can understand if the child is too small or not. If the child is too small, usually the gynecologist or the obstetrician will ask the mother to put on some weight, to have for more nutritional food and put on some weight so that the child can also gain weight. Okay. So it is divided into two categories: healthy small for gestational age or constitutionally small baby, and true intrauterine growth restricted baby. So they have intrauterine growth restriction, which is pathological. They will have higher mortality and morbidity chances. Okay, but healthy small for gestational age babies or constitutional small babies, comparatively, they will not have much morbidity or mortality. Okay. So IgE type 1, type 2, you don't have to study. You just have to understand this classification. Okay. For constitutionally small babies, we just have two classification. One is healthy, small for gestational age babies, and one is intrauterine growth retardation babies. Okay. In intrauterine IUGR, intrauterine growth retardation baby, mortality and morbidity rate is quite high as compared to healthy, small for gestational age or constitutionally small babies. The risk factors for non-communicable diseases in a constitutionally small babies, higher birth weight. Okay, that is also a risk factor of non-communicable diseases. Like in, for example, the babies who are obese or they are born with a much heavier weight, they have a higher risk of developing cardiovascular diseases later in the life, diabetes, type 1 or type 2 diabetes later in the life. Okay, higher length and weight at first birthday. At the age of 1 year, if the child is overweight or obese, that could also lead to non-communicable diseases. Non-communicable diseases means lifestyle diseases when they become into a adult. Early catch-up of growth. Early catch-up of growth, that is also an indicator of non-communicable diseases. Means the sex hormones, the sex steroids are working quite early in their lives. Okay, and that could have another impact on non-communicable diseases. Early adiposity rebound. For adiposity means too much of fat cells in the child. Okay, and that came back. Fat cells which was lost, but the fat cells came back immediately. That could also lead to non-communicable diseases. And other parameters which are attained at puberty. Okay, even in puberty, if the BMI is quite high, that could also lead to non-communicable diseases. So the growth potential is not something that one can speed up and slow down. It is completely dependent on growth hormones, sex steroids, nutritional factors. Okay, purposefully you cannot speed up a person's growth or slow down a person's growth or a child's growth. It is completely dependent on these factors. Okay, if these factors are working healthy, they are being secreted healthy, and the other environmental factors are also being taken care of in a healthy way, the child will have a healthy growth. Okay. Next, we have growth monitoring by healthcare professionals. So routine monitoring is mandatory in young children and infants, because if there is any sign of abnormal growth, either too much of growth or too less of growth, it can be caught early and we can intervene it appropriately. Okay, and also to suggest timely nutritional interventions, what supplements has to be given, how to correct the nutritional deficiencies. Growth monitoring on a regular basis is mandatory. Okay, and also to prevent growth faltering. When the child was healthy, born healthy, infancy was also healthy, but when the child went into childhood, preschool age or school age, the child is become malnourished and growth faltering begun. Means the child is falling down the road to a health map. Okay, so to prevent that also, we have to focus on growth monitoring. So growth chart are recommended by WHO. I'll show you the growth chart at the last part of the child. What is the World Health Organization recommended growth charts? There are various many growth charts. You can use any one of that. So weight monitoring, how to do weight monitoring, digital scale should be used. And if the child is wearing heavy shoes or heavy clothing like sweaters and all, remove that. Both the feet of the child should be on the center of the scale and the weighing scale, and the child should stand straight. Okay, and when you are recording the weight on the digital scale, decimals also has to be considered. The nearest decimal fraction has to be considered. Okay, like if the decimal is less than 0.5, go to the lowest number. If the decimal is more than 0.5, go to the larger number. So this is how you do the weight monitoring. Height monitoring, again, remove the bulky shoes. Okay, bulky shoes and bulky clothing has to be removed. Take the height measurement. Remove shoes, bulky clothing, hair ornaments, etc. Always make sure that you take the height measurement on hard falling flooring, not on soft floor, not on carpets or mattresses. The child should stand straight on hard flooring, wooden floor or tiles. Against the wall, the child has to stand straight. Look straight. Child has to stand looking straight. Which chin should also be straight. Feet should be flat and together. Both the feet should be together against the wall. And when you are measuring the topmost part of the height, head piece, a flat headpiece should be used, and the flat headpiece should form a right angle with the wall, and lower headpiece until it firmly touches the crown of the head, not below the crown or not over the crown. Okay, it should touch the crown of the head, and it's better to use the steel scale. Okay, that is a flat surface, and you have to mark and you have to measure the floor to the marking. Okay, so that's how you do the height monitoring. So growth charts, you have mother and child protection cards. I'll show you what it is. Okay, well baby clinics are there for under 5 and well baby clinics along with PHCs. Okay, well baby clinics will also do the growth monitoring. They are a part of ICDS programs as well. They will do give out supplementary nutrition as well as a part of nutritional programs. They also carry out the nutritional programs, government-led nutritional programs. PHCs, primary health centers are also available. They can also monitor the growth chart. Okay, ICDS programs, Anganwadi programs, ASHA workers. Okay, they are all other part of the ICDS programs and schemes. They can also take part in monitoring the child's height and weight and head circumference as well. Then we can follow the road to health chart. Okay, so these all growth charts. These all are the areas where growth charts are used. So this is the road to health chart. So you see the green area. This is where a child should be. A normal healthy child should be in this green area. You can see here birth to first year how the growth chart should be. 1 to 2 years. Okay, the child should be in this area. 2 to 3 years, 3 to 4, 4 to 5, and so on. Okay, if the child is going above this growth, above this green, okay, if the child is in this area, that is also a matter of concern. The child may suffer from gigantism. If the child is falling off the growth chart, okay, if the child's measurement, height and weight measurement, okay, is falling down, okay, that is also another concern. Usually it is it is malnourishment. So you can see here analogies are given. If the child's growth is steady, like it is going upward steady, it is good. If the child's growth is stagnant, okay, it is neither going up not going down, it is danger. Okay, you have to find out why. And if the child's growth is going down or weight is going down, it is very dangerous. Okay, so this is the growth chart or road to health chart. Every child should be in this green area. Okay, this green area is a normal area. It is called the road to health. Then we have the mother and child protection card, MCP card. So this card is used to track the tracking of each child right from the conception till 3 years of age. Okay, so mother is also checked here, the fetal growth. The mother's health is also checked here along with the child's growth till 3 years of age. From before when the mother is pregnant, okay, mother's entire pregnancy and birth, and after birth up till the age of 3, the child's health is also checked by the community health workers, ASHA workers, Anganwadi workers. Okay, they all are part of this of maintaining the MCP card. And it is also used to counsel the family and also empower the family wherever nutritional status has to be checked and has to be corrected. Okay, this MCP card can be used as an empowering tool. Okay, so this MCP card acts as a bridge between beneficiaries and health system. Okay, the health system means the government-led health programs, and the beneficiary is the population, through which a continuum of care services like antenatal care, postnatal care, immunization for the mother and child, growth monitoring of the child, referrals if there is any deprivation, any malnourishment issues, infectious conditions, mental health issues. Okay, referrals can be given at the right point of time. because of this MCP card. So these are all are the areas through which MCP card works. Then we have the percentile and Z-score chart, which means the bell-shaped curve, Gaussian curve. Okay, so you can see here standard deviations. Okay, plus or minus. This mu, which you see standard deviation. So when you collect data, for example, if I give you the task of go to a community and find all the 4 to 5 year old child, find 4 to 5 year child or a year old child from a community and plot their weight in a graph. Okay, you will get this bell-shaped curve. Okay, what it says is that, let's say 4 to 5 year old child is around 10 to 12 kg normally. Okay, so 10 to 12 kg will be in the x-axis. Okay, around like 9 kg, sorry, 8 kg, 9 kg, 10 kg, 11 kg, 12 kg, 13 kg, like that. So majority you will see the highest number of children are in the 10 to 12 kg range. Okay, and all the other majority, the 99% will be within the 8 to 13 range. Okay, and the second majority will be between the 9 to 11 range. Okay, so this is what a normal curve chart or a Gaussian chart tells you. Okay, when you take an age group, when you plot their height and weight, you will always get a bell-shaped curve, because bell-shaped curve means what? Majority of the data, majority of the children, most common weight or most common height is condensed in one particular area. So that particular area is considered the average or normal weight gain for a child for that particular age. Okay, so this is the normal curve. Percentile means this, when you deviate on the right or left. Okay, for example, this is the center is 0. Okay, the center will be 0. Mean median mode, it is considered 0 because it's a graph. Okay, so mean median mode here is the same number. Mean median mode, if you check, it will be the same number. If you go 10 units this side, it means 10 percentile. Okay, 20 units this side, you will go 20 percentile. Okay, 30 units this side, you will go 30 percentile. So when I say the child is below 30 percentile of a normal, so this yellow part, this orange yellow part is a normal. When I say the child is 30 percentile below normal, means the child is somewhere here, the child's weight gain is somewhere here. Do you consider it normal? Let's say this is 10 percentile, 20 percentile, 30 percentile. So when I say the child is in the 30 percentile, the child's weight is less than 30 percentile of the normal. Okay, the child will not be normal. Okay, when I say the child's weight is 10 percentile of the average, 10 percentile of the average, is it normal, or is it healthy, or is it abnormal? 10 percentile will come somewhere here in this pink part. It is still normal. Okay, 10 percentile will still be normal. Okay. So this is how you use a Gaussian curve or a normal chart. Then we have growth velocity. For height and weight, we have growth velocity. So growth velocity for weight, yeah, it is near to average. 10 percentile is near to average. 20 percentile, the more you go far from the average, means you have an abnormality there. The more closer you are to the average, it's normal. Okay. Growth velocity for weight. Any pre-pubertal child whose weight velocity is less than 1 kg per year should be monitored carefully for progressive nutritional deficit. Okay, so before the child achieves puberty, on a yearly basis, if the child is not even putting on 1 kg of weight, which means there is some nutritional deficiency. Okay, after puberty, during puberty, and after puberty, the weight gain is much more rapid. Okay, within a year, the child may gain 2 to 3 kgs. In some cases, 5 kgs within a year, because growth spurt is taking place. So before puberty, if the child is gaining less than 1 kg per year, there is something wrong. After puberty, the weight gain is more. Peak weight velocity is generally between 1 to 4 kg every 6 months for a teenager, okay, in a healthy population. So that is the growth velocity for weight. Now coming to height. Coming to height, the growth velocity per year, birth to 12 months, 23 to 27 centimeter. Till first year, 10 to 14 centimeters should be the growth. Growth means from the time of birth. Almost the child will be 50 centimeter at birth. Okay, maximum 50 centimeter is the birth height. Okay, so before the 12th first birthday, 23 to 27 centimeter height would be there. The 12 months to first year, okay, that is the second birthday, this much should be the growth velocity, and so on. You can take a screenshot of this. In puberty, 8 to 12 centimeter should be the growth velocity per year on a yearly basis. For boys, it is much higher. In puberty, 10 to 14 centimeter growth on a yearly basis. You can take a screenshot for later reference. Next, how do we calculate a child's height, if it is normal or abnormal? Subjective. Yeah, recordings will be available. Yeah. So this is how you calculate the a child's you can predict the child's height. Okay, what will be the child's height in the future? You can predict this. If it is the boy, if it is boys, father's height plus mother's height plus 13 divided by 2. Okay, that in that you can get the child's average height. Plus or minus 7.5 centimeter. Either the if the range is plus or minus 7 centimeter, whatever answer you get, okay, plus or minus 7 centimeter you can do, you will get a boy's average height. If it is a boy child. If it is a girl child, father's height plus mother's height minus 13 divided by 2. Plus or minus, whatever is the answer, plus or minus 6 centimeter is a normal range. Okay, so this is how you can predict the child's height. The child has not reached this height yet, but this is how the mature height should be. A mature child's height should be based on the parent's height. Okay. This formula is given in the textbook on page number 166. You can refer that. This is the prediction, height prediction. Okay. So if the child is nowhere near this prediction, there is something wrong with the nutrition, or some abnormalities could be wrong within the child. Okay. Please WhatsApp me for the link. Now this is the WHO growth chart. There are different growth charts given in the textbook. You can refer that later. Page number 168 onwards, lot of growth charts are mentioned in the 168 to 178, 10 pages of growth chart. Different forms of growth charts are mentioned. Okay, always remember, in growth chart, the x-axis is age, it is time, age. Okay, and then the y-axis is weight, or in some cases, some growth chart it is height. Okay, based on what kind of growth chart we are looking at. Height and weight has two different growth charts. For girls and boys, there you have different growth chart. BMI growth chart is also given. Arm circumference chart is also given. You can refer that. Okay. For girls and boys, you have different indices. So that's all for today's session.